This lecture is about Staphylococcus aureus bacteremia. The definition is when Staphylococcus aureus is isolated from one or more blood cultures. When a blood culture is positive for this organism, it should never be considered a contaminant and should always be taken seriously. There are two possible sensitivity patterns. That's methicillin-sensitive Staph aureus, which means it's sensitive to beta-lactams such as cloxacillin, coamoxiclav, cephalosporins, and carbapenems, and methicillin-resistant Staph aureus, which is resistant to all of those antibiotics. Staph bacteremia, or SAB, is common. The incidence is up to 3.7 cases per 1,000 admissions in hospitals in Gauteng, and it's the second most common pathogen recovered from blood cultures at Groote Hospital. It's also serious. The all-cause mortality globally is around 20 to 30% at 30 days. And MRSA, which is the resistant form, accounts for up to 50% of SAB episodes in adults in South African hospitals, and an even higher proportion in pediatric hospitals. The most important risk factor for SAB is the presence of intravascular foreign material. This is usually peripheral or central intravenous catheters. Other risk factors include injection drug use. Patients from the community who have been injecting drugs can introduce Staphylococcus into their bloodstream, leading to infection. Other risk factors are comorbid medical conditions such as HIV, and any other prosthetic material such as artificial joints, prosthetic heart valves, or pacemakers are risk factors for infection. Often no clinical source is found, although we often look for sources such as infected wounds. Commonly these are not found, and when this happens it's associated with a worse prognosis. In terms of clinical manifestations, SAB can present either acutely or subacutely. Sometimes the symptoms are very non-specific, and the patient just presents with a febrile illness with no obvious focus. On other occasions, there is specific organ dysfunction which points to where the source of infection is. Specific areas that are involved commonly are bone and joint infections, including vertebral osteomyelitis and discitis. The patients can present with pneumonia. They may also present with endocarditis. They may have deep-seated abscess formation, and rarely they may have meningitis. Once SAB has been diagnosed, we need to divide patients into those with complicated and uncomplicated disease. Uncomplicated disease is patients where endocarditis has been excluded, who have no implantable devices, and who, when they have a blood culture taken after 2 to 4 days of initial therapy, that blood culture is sterile and therefore the bacteremia is cleared. They also need to have had a defervescence of fever within 72 hours of initiating effective therapy. And there must be no evidence of metastatic infection when the patient is examined. Complicated SAB is all patients who do not meet the criteria for uncomplicated Staph bacteremia, i.e. they have one of the 5 things listed above. This occurs in over 40% of cases and is associated with worse outcomes and requires a longer duration of therapy. This is a suggested management algorithm for patients with SAB. The first and most important thing to do is remove or replace any indwelling vascular devices and start the patient on cloxacillin 2 grams. If the organism is known to be resistant and therefore is an MRSA, then you must start vancomycin. The next question is whether the patient has a prosthetic heart valve or any endovascular prosthetic material. This represents a special case. These patients should be started on 3 grams of cloxacillin 6 hourly, plus gentamicin and rifampicin, and it's imperative that they are referred to a tertiary institution for further specialist management. For all other patients who don't have prosthetic material in the heart or endovascularly, they should have their blood cultures repeated after 72 hours of effective therapy with cloxacillin or vancomycin. This critically defines the rest of the workup. If that blood culture is positive, by definition the patient has complicated infection. They need to complete at least 4 weeks of antibiotics. They should continue to have repeat blood cultures every 72 hours until the bacteremia is cleared. And you need to look very carefully at the patient from a clinical standpoint to see if there are any sources of infection that need to be investigated. If the 72-hour blood culture is negative, then the question is whether the patient has community-acquired infection, which is a risk factor for endocarditis, or has any clinical features of endocarditis. If not, then the patient should complete 2 weeks of intravenous therapy. You should search for a source based on clinical features, or if the fever doesn't settle. If the patient does have community-acquired infection or features of endocarditis, they need to have an echo. It's likely that the echo that will be available will be transthoracic. If that's positive, then the patient has endocarditis. You need to increase the dose of cloxacillin, and if possible, you need to involve specialists. If endocarditis is ruled out, then the patient requires 2 weeks of IV therapy as before. So in summary, SAB is defined as a single blood culture positive for Staph aureus. MRSA is resistant to all beta-lactam antibiotics. SAB is a common and a serious infection. The most important risk factor is intravenous catheter use. It's important to exclude complicated infection. All patients with SAB require at least 2 weeks of antibiotic therapy, and outcomes are improved if management algorithms are followed.